Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Sue Talakat from the Bloomberg American Health Initiative. Are you and your organization working to reduce overdoses, end violence, improve food systems, protect the environment, or support adolescents in the United States? If so, you may be eligible for a full scholarship to earn an MPH or DRPH degree at the Johns Hopkins Bloomberg School of Public Health. The Bloomberg Fellowship through the Bloomberg American Health Initiative can help you transform your career, support your organization, and make a significant impact on your community. Find out more at americanhealth.jhu.edu/fellowship.
This is Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmon talks to psychiatrist Dr. David Goodman, director of the Adult Attention Deficit Disorder Center of Maryland, about ADHD and aging. As we age, a certain degree of forgetfulness or decreased ability to mentally multitask is expected. But how can you tell what's normal from what could be cognitive impairment or undiagnosed ADHD? And how can ADHD diagnosis and treatment change lives and potentially stave off further cognitive decline? Let's listen.
David Goodman, thanks so much for joining me again.
Hi, Stephanie. Thanks for having me back.
Today, I want to talk to you about ADHD and aging. But before we launch in, you and I did a podcast earlier this year about ADHD in adults in general. And if you could sort of remind our listeners what the takeaway message from that was.
So attention deficit hyperactivity disorder, ADHD, is common in children. 60 to 90% of the children will continue to have symptoms into adulthood. We had not recognized this until about 20 or 30 years ago. Professionals are not trained in their professional programs, and so everyone's learning this on the fly. In adults, you see it as inattention, disorganization, distractibility, inconsistency that's lifelong. And often the symptoms are so severe that they lead to impairments that are recognized by others. This is now a recognized disorder in the DSM-5, and international research supports the validity of this diagnosis. What we're going to talk about today, and has not heretofore been discussed, is that the adults age into older adults. So those over the age of 50, 60, 70 continue to have ADHD symptoms that are unrecognized and often ascribed to anxiety or depression, or just you're not a spring chicken anymore.
So why is it important to discuss the middle-aged and older crowd?
Well, we know that as we age, our cognitive abilities slowly decline. We all recognize that if you're over the age of 50, you notice that you might have difficulty finding words, you might have difficulty recalling names, you may be stumbling over words, spelling words that you hadn't previously done. And so people accept this as part of the aging process. There are several segmented populations that I'll focus on. One is women. As you go through perimenopause and into menopause, there is a cognitive decline, and there is some emotionality that becomes a bit dysregulated. It's easy to discount this and say, well, you're going through perimenopause. But if you had ADHD your whole life, those ADHD symptoms may be worsened in the perimenopause phase because your estrogen is declining, and estrogen helps cognition. So as you start losing some of your estrogen, your cognition declines. If you don't make the diagnosis of ADHD and simply discount this as perimenopause, you lose the opportunity to treat somebody with an identifiable diagnosis and very effective treatment. Now, the same thing is also true as men get older and testosterone levels decline. In general, as you're aging, your brain is maturing, if you will, perhaps not aging, as I would like to not think of. But there are certain realities here. The point to be made is that making a diagnosis of ADHD in someone who's in their 50s, 60s, and 70s gives you the opportunity to provide effective treatment in terms of prescriptions, of medications that are effective for ADHD, as well as psychotherapies to help these people adjust and accommodate to the change. Executives, business people, professionals notice this in the sense that their ability to manage multiple balls in the air becomes more and more challenging. It becomes more of a cognitive effort. People really worry, though, when they start stumbling significantly. They lose their keys, they're forgetting their appointments, they're misplacing their wallet. We all do this, but if you're doing this on a daily basis, then it becomes quite evident. And that may be something we call mild cognitive impairment, which 40% lead to dementia, and that's the fear amongst people who are getting older. So coming back to what's the point of ADHD? ADHD is a recognizable diagnosed disorder that can be effectively treated and can diminish the rate of cognitive decline if it's diagnosed and treated.
So how do we tell the difference between the fact that I couldn't remember someone's name yesterday and whether that's a symptom of ADHD?
So the difference here is historical trajectory. If you have ADHD, you've had these cognitive symptoms and impairments your whole life. You can say, I was this way 5 years ago, I was this way 10 years ago, I was this way 20 years ago. It just seems now, though, that it's worse. Now, it may be worse because the demands of the environment have increased. It may be worse because you have a medical illness that's also compromising your cognitive ability. It may be worse because you're on 3, 4, 5, 6 different medications. They can have subtle effects on your cognitive ability. So in the differential diagnosis, that is, the disorders that we consider as we evaluate somebody, we have to sort out which of these factors may play a role here. And ADHD is one of them. Again, you don't develop ADHD at 50, 60, or 70. You develop ADHD as a child and early adolescence, and those symptoms are chronic and unchanged. If someone comes to me at 53 and says the symptoms have worsened over the last 3 years, and I wasn't this way 10 years ago, then you don't have ADHD. You have some cognitive changes now that I have to find the medical explanation for. So that's how you sort it out. It really isn't based on the symptoms in the present. It's based on the history of the symptoms over the course of time.
So if I am in my 50s and I get a diagnosis of ADHD, you can treat me with medication.
Correct. We use the same medication in a 53-year-old with ADHD that we use in a 27-year-old with ADHD. Now, I might make it more complicated, and that is, it's not a binary decision. That is, it's not that you have ADHD or you don't have ADHD. It's that you have ADHD and you may also now have age-related cognitive decline, which is a different neural network than your ADHD. So you can go on to have ADHD and age-related cognitive decline, which is normal. You can have ADHD and mild cognitive impairment, which is more severe. Again, these are different neural networks. If you treat the ADHD, even if you have mild cognitive impairment, you improve the cognitive ability and you slow the rate of decline.
So left untreated, it's going to potentially cause more symptoms than it would have otherwise.
Left untreated, the ADHD will be additive to whatever the age-related cognitive issues are. So if you have cognitive symptoms from ADHD, you add on cognitive symptoms from multiple medications, you add on cognitive symptoms from age-related or mild cognitive impairment, these become additive, and now you can see how your cognitive decline is exacerbated by the presence of all of these coexisting just diagnoses. And that's why we can take one off the plate by treating the ADHD. Now, the prevalence rate of ADHD in adults over the age of 50 is about 3%. This comes from international research in the Netherlands. The prevalence rate of ADHD in older adults is about 3%. So 3% of 75 million is a lot of people. But if you dial it down to the single patient, if your mother has ADHD and mild cognitive impairment and you put them on medication for their ADHD, you're going to slow the rate of cognitive decline. You're going to continue the quality of life out for a longer period of time. And also, you'll forestall this demoralization at the decline in functioning during the day.
So there has not been a lot of research on older folks and ADHD, has there?
There has not been. I actually am the lead author on the first publication of the literature review. We published this back in 2016. There's now been a substantial amount of work, both at a patient level and also at a neuroimaging level, trying to distinguish ADHD from other cognitive processes. One of the elements that has scared people in the public media is the association between ADHD and Alzheimer's, ADHD and Lewy body dementia. So there are some risk factors here in having ADHD and leading into Alzheimer's and other dementias. I say that just in a cautionary form. I don't want people to panic. Oh my gosh, this is the trajectory of the aging and end of my life. This is preliminary research, and the neuroimaging really has to sort out the difference in the neural networks between ADHD and the other cognitive processes.
That sounds like a difficult task.
It is extremely difficult, and it's made even more difficult because the training in professional training programs is non-existent. That I'm one of the leading experts in this area, and it's very important that clinicians start putting this on the differential diagnosis when older adults come in complaining about cognitive decline, because every once in a while you'll find somebody with ADHD. You can treat them and you look like a genius. The patient is grateful, their family is grateful, and life continues so much better. The great news is that the research community is now focused on this very much. They want to try to tease apart the ADHD from the mild cognitive impairment, from the Alzheimer's, and so we can provide additional treatment in order to extend people's functioning and quality of life.
I appreciate what you're saying because I think that a lot of people might feel like, well, I'm in my 50s and I was never diagnosed before, so how is a diagnosis going to help me?
That is a great question. And so people will say that. I lived my whole life. Clinicians' biased is, look, even if you have ADHD, you lived your whole life, you compensated, you're doing well, you have a family, you're living on your own. Why bother treating this? Oh, and by the way, you're too old for me to put you on stimulant medications because you'll end up having a heart attack and a stroke. These are the clinical biases that providers have and that patients have. I will tell you, however, that if you treat these people, they will come back and say, I had no idea. Is this how normal people live? Remember, you're 53 years old. You've lived your whole life in this state of mind, believing the criticism of the environment, that you're lazy, that you're inconsistent, that you're the weak link in the chain. And this becomes integrated into your self-esteem. Imagine now that I gave you something for your blurred vision and you said, oh my gosh, I now understand the difference between what I have, ADHD or blurred vision, and who I am as a person. So regardless, showing people the comparative effect really liberates themselves from the negative criticism and self-esteem issues that they've had. And even patients in their 70s and 80s that I've had who say, gosh, I'm so sad about all the opportunities missed in my life. I now realize that the environment was not right, that this is something I have. It's not who I am as a person.
Really very interesting. You mentioned that the Netherlands research says 3% of the population has ADHD. Now, those, of course, are people who've had it their whole lives as well. I mean, all the people with ADHD have had it their whole lives, but these are people who have, some of them, many of them have known their whole lives. We have ADHD, the kids in our family. How is that going to affect them as they age?
Well, how ADHD affects them is going to be based on a number of things. One is, did you get formally evaluated and get a diagnosis? Because once you get an accurate diagnosis, you can no longer in the future say, if I had only known, I would have done things differently. Once you have a diagnosis, there's an explanation as to why your brain functions the way it does and how it causes you to function the way you do in the world. Now, rather than being a victim of your ADHD, you become a master of your ADHD and deciding how you want to compensate, how you want to arrange the environment, how you want to conduct your relationships with people who know and are supportive versus those who are critical and eye-rolling. You also have the opportunity to try medication, which is highly effective. In fact, stimulant medications have one of the highest effect sizes of all medications in all of medicine. I mean, they're remarkably helpful. Now, medicine is not the end-all and be-all, and learning new compensatory skills to organize yourself to help people around you, help you to have conversations with your spouse and say, look, I'm not doing this to you. I don't show up late. I don't forget just to torture you. This is just my ADHD. Let's figure out a way to communicate so we can best coordinate what we need to do.
So knowledge is power here.
Knowledge is absolutely power. My goal as a clinician is not to tell you what to do with your illness. My goal is to provide as much information as I can for you to decide how you want to manage your illness. This is no different than having diabetes, where you have to adjust your exercise pattern and your food choices. You can choose to do that or you can choose not to do that. But 10 years, 15, 20 years later, you can't tell me I didn't know and I would have done things differently.
David Goodman, thank you so much for your time.
Stephanie, this was wonderful. Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.